Again?
I'm recording starting now.
Okay. Well, welcome everybody to today's Learning Collaborative. Thank you for taking time out of your summer schedules. I know that's not easy. The sort of agenda for today is in part one. Dr. Jonas and I are going to be talking about two very common pediatric epilepsy syndromes. We'll walk you through two vignettes. Following that, we'll do our usual quality improvement discussion. The discussion over the past months has been around the implementation of the seizure screener. We're making nice progress in that area. I think somebody online is going to need to mute, perhaps, or Christina can help you with that if you're having any challenges. And then during the didactic, feel free to ask questions, and I'll also leave time at the very end in case there's questions as well. I hope everyone online can see the slides just fine. Let me know if you can't. Christina, are we check? Are we good? Yeah,
We're good.
We're good. Okay, great. So welcome to part one. So objectives for today is, one, I want to increase the awareness of the two common pediatric epilepsy syndromes. There are many, many of these. We chose just to focus on two that you will commonly see. One being childhood absence epilepsy and the other benign Rolandic epilepsy. The second is understand the natural history of these two epilepsy types. And last, to recognize some common seizure types, including absence, complex partial, and focal motor. I'm going to go over a vignette of a case of absence epilepsy, and Dr. Jonas is going to go over a case of benign Rolandic, so we'll be taking turns. So during this, we're going to focus mostly on childhood absence epilepsy, but I will also touch on some of the other absence epilepsies. So here's our clinical vignette. A 6-year-old girl is brought to clinic by her parents for staring spells. The first grade teacher noticed her staring in class and brought this to her parents' attention. The parents now notice the staring spells as well at home. So what would we want to ask the patient and family? Staring, as we know, is very common. What sort of separates this kid out from other children who come in with the same sorts of complaints? Well, we want to find out if there's an aura. Is there any warning sign before the staring? And are there any symptoms after? Now, if that were the case, we'd be thinking more along the lines of a complex partial seizure, or what we call now focal seizure with altered awareness. Are there automatisms? And I'll show you some examples of these. These are lip smacking or eye blinking or chewing movements or picking-like behaviors. I think practice of teaching has been to say that's typical of complex partial. However, it really is for either absence or complex partial. Automatisms come with the duration of the seizure as opposed to the seizure type. So they are not specific for one type over the other. Also, how long do they last and how frequent? Absence seizures tend to be very frequent, multiple times in a day, as opposed to a complex partial, which may be more rare. And the duration often is seconds. For complex partial, maybe seconds to minutes. Are there triggers? What brings it on? For some types of epilepsy, some types of absence, light, flickering lights might be a thing. It might be the time of day. So that's very important to ask. Can they be interrupted? And this is hard. For absence seizures, they last seconds. By the time the parent recognizes the child is staring, goes over and taps them, they're probably out of it. Even in our own EEG lab, when our techs see the seizure coming across the screen, by the time they alert the child, it can be very hard to determine if there's an altered awareness. Is the child aware of the events? You would think if they're aware, well, either it's not a seizure or it's complex partial. However, for adolescents who have a juvenile type of absence epilepsy, it's not uncommon for them to tell us that they're partially aware that they're having events. Not typical for childhood absence. They usually are not aware of their events. Are there any other seizure types? Because then maybe we can classify it into a particular epilepsy syndrome. And is their development normal or abnormal? Children who have childhood absence epilepsy usually have normal development, whereas there are some other syndromes that have absence epilepsy and the development's abnormal, and that will push you in a different direction. So here's our differential. Most common thing would be daydreaming. All of us probably stare at some point of our day. But however, usually we have some recollection of what we were thinking about. Is it ADD or ADHD? This would be a very reasonable time. A 6-year-old girl comes to the pediatrician's office, is staring. Often girls tend to have more the ADD type as opposed to the attention deficit hyperactivity type. And so perhaps they're actually coming to attention for that as opposed to seizures. Are they being oppositional or ignoring our requests? Any of us who have children have experienced this. Is the child depressed? Are there learning or intellectual problems? Maybe they're just very slow in processing the information. They're staring because they do not know how to respond. Again, first grade, a really common time to be picking up on these problems for the first time. Is there a hearing impairment? Or is it seizure? And again, I told you we're going to focus on absence seizure versus a focal seizure with altered awareness. So we'll compare the two, absence versus focal with altered awareness, which is the new name for complex partial seizures. So with absence, there's no aura and no postictal symptoms. With the complex partial seizures, they often have an aura and will have postictal symptoms. Absences are usually brief, lasting seconds. And for focal or complex partial, seconds to minutes. Both can have automatisms. That does not distinguish the two. The EEG does help us. So for absence epilepsy, we will see generalized spike waves. And depending on the absence epilepsy type, they will fire at a different frequency. I'll show you some examples. Childhood absence is 3 hertz. This is very commonly asked on the pediatric boards. Juvenile absence is a fast spike wave, greater than 3 hertz. And a typical absence, less than 3 hertz. Again, another question commonly asked on pediatric boards. As opposed to the EEG for those who have complex partial seizures, the routine EEG, meaning the EEG when they're not having events, may be normal or show focal spikes. And then if they're having a seizure, which is something we record with video EEG, it can be hard to see, but you would expect to see a buildup of spikes in one region that may actually involve both temporal lobes, for example. This is an EEG of a patient with 3 hertz spike wave of childhood. What you can see in every single lead here as we go down, there are spike waves. And it might be a little hard to appreciate the time intervals, but from here to here is 1 second. And I'm hoping you folks can see my mouse. Can you all see my mouse? Maybe. Christina, let me know if you can't see my mouse. You can. Okay, great. There's also this little cursor here, this little marker to show you that this is 2 seconds. So basically all we do is count up 1, 2, 3, and that's how we know it's 3 hertz. At the bottom here, you see some notes. HV 100 seconds. That means the child's been hyperventilating for 100 seconds, which is one of the ways that we can bring out the seizures in the EEG lab. This is a little bit different from here to here, being 1 second, dark green line to dark green line. And you can see there's only 2 per second. This is very typical of atypical absence seizures, which is something you would see in children, for example, with Lennox-Gastaut syndrome. We'll be talking about that in another learning collaborative meeting. You may remember this video from one that Dr. Jonas showed you in the past. This is a young lady who's having an absence seizure. And maybe some of the pediatricians might guess how old she is, but I'm thinking she's 10 or older, maybe 11 or 12, which definitely comes into the equation of figuring out what type of epilepsy she has. And notice she pauses. She has a little bit of repetitive swallowing, a little form of an automatism. And then she's back. This is a younger child, pretty typical of the little vignette that we presented at the beginning of this talk today. And I'd like to run his. He's doing some homework, it seems, with one of his parents. And see his eyes start to flutter up. And then these mouth movements are another automatism. His arm starts to raise and he's right back to normal. He missed what Daddy was trying to tell him. And here's a second one. And sometimes these are so quick that parents and teachers will miss them, which makes it hard on the child. So let's talk a little bit about treatment. This is one of the few epilepsy types that we actually have a head-to-head trial comparing 3 different medicines to figure out which one was more efficacious. If you want to read more, you can go to New England Journal of Medicine from 2010. And in this study, what they did was they took children who had childhood absence epilepsy, and they compared ethosuximide to valproic acid to lamotrigine, and they wanted to figure out which one controlled seizures the best. And what you can see is over time, lamotrigine seemed to fail for about 50% or more of the kids, whereas ethosuximide and valproate seemed to work the best, not perfectly, but the best. I'm not going to show you the slide that shows side effects of each, but the end conclusion of this study was that valproic acid and ethosuximide work equally well. However, side effects are lowest for ethosuximide and lamotrigine, particularly in terms of exacerbating symptoms of attention deficit disorder. And for that reason, we've gone back to the old standard therapy of ethosuximide now being the choice for childhood absence epilepsy. What's the prognosis? So childhood absence epilepsy remits by 12 years. "20% have generalized tonic-clonic seizures, usually in the preteen years. So what that means is onset's often 5, 6, 7 years of age, or at least when it gets recognized. And during those early years, they're really just going to have absence seizures. Ethosuximide, the treatment of choice, only works for absence. If they actually had a generalized tonic-clonic, we would need to pick a different medicine. Fortunately, when it does happen, it's happening at the offset, almost when it's going away. These children have normal intelligence, and quality of life can be excellent. It should be excellent. What really happens, it's dependent if there's other comorbid conditions, such as depression or anxiety, as well as the parental response. So if the parents are very calm and actually try to allow the child to live a full life, their quality of life is also excellent. There are 4 other syndromes, just to mention briefly. There are many more than what I've put on this screen. The common one I presented to you today is childhood absence type. Later, in another session, we'll talk about juvenile absence epilepsy. They present very similarly with absence seizures. They tend to have shorter absence seizures and less frequent per day. They also may not start presenting with their absence seizures until, say, 9 or 10 or even in their early teens. And they are far more likely to have generalized tonic-clonic seizures early on in their epilepsy. Another type of epilepsy I mentioned earlier, Lennox-Gastaut syndrome, again, we'll talk about it in another session. These are children who have abnormal development or developmental delays, and they may have atypical absence when they present. And then there's another syndrome called eyelid myoclonus with absences, usually presenting in the preschool years. And it can be very tricky to treat, often goes on for many, many years into early teens and into adulthood. At this point, I'm going to turn over the headphones to Dr. Jonas, who's going to talk to you a little bit about benign Rolandic epilepsy.
So I will talk a little bit about benign Rolandic epilepsy. And like Laurie said, lately we have a lot of new names for old syndromes. And even us, we are not used yet to the new terminology, so we're going to use it interchangeable. So nowadays, we call it actually self-limited epilepsy of childhood with central temporal spikes, which used to be in the past the benign Rolandic epilepsy, or the benign epilepsy of childhood with central temporal spikes. And the name benign was taken away because despite the fact that it is an epilepsy that is usually easy to control, we do see some comorbidities, especially with learning and behavior. So it was felt that the name benign doesn't actually fit into this condition. However, it's usually self-limited, and this is now the new name. So I'll give you another vignette. So we have a 6-year-old boy with normal development. Christmas morning, he comes to his parents' room. He's unable to talk, and he has some twitching on the left side of his face. He seems to be able to look at parents. He's drooling, especially from the left side of his face. Within about 2 minutes, it goes away. He's a little bit tired for a few hours after that. On the second night, he's in a sleepaway camp. His counselor hears some grunting from his bunk. When he checks on him, he's shaking all over. The event lasts for less than 2 minutes. The following day, he's able to participate in camp activities and looks totally fine. So this is a typical story in children who have benign Rolandic epilepsy, and this is the name that I'm going to use today. And we look at this boy, who's probably 13 or 14, which is kind of a little bit older than the typical children who would have benign Rolandic epilepsy. And as you see, we see some clonic activity and pulling on the left side of his lower lip and cheek. It is unclear here if the child is actually conscious or unconscious. We see that it's rhythmic, which is very different than what we would see, for instance, with tics, that we might have some facial motor tics. We see also some drooling. And it is actually typical for seizure that we can see a little bit change in the rhythmicity and the frequency from faster to a little bit slower. And now he's done. He seems to be tired, needs some reassurance from parents. And then after a few hours, will be back to himself. So benign Rolandic epilepsy is actually the most common form of idiopathic partial epilepsy. So compared to what Lori presented, the childhood absence epilepsy, which is considered generalized epilepsy, this is an epilepsy that starts focally in one area of the brain. It accounts for about 15 to 20% of all childhood epilepsies. The onset can be anytime between age of 3 to 12 years, but the peak is usually around 7 to 9 years of age. And most seizures stop within 2 to 4 years after they begin. And in almost all of them, we see remission by age 15 to 17 years. The etiology is likely genetic. There is about 10% family history of either febrile seizures or epilepsy. And interestingly, there's quite a high number of family members who might have just the abnormal EEG without actually having the seizures themselves. The seizure frequency is usually low. About 10 to 20% will have only one single seizure and will not have any again. About 20% have frequent seizures. Less than 2% will actually have seizures into adulthood. And status epilepticus is very rare, usually less than 2%. There is some comorbidities, like I mentioned before. The children usually have normal intelligence and they do not have long-term learning difficulties. However, during the active phase of the epilepsy, they may have transient speech deficits, they might have verbal and nonverbal memory deficits, they might have some behavioral disorders that usually resolves. The seizure types that are most commonly seen in benign Rolandic epilepsy is what we used to call simple partial seizures, and we call nowadays focal motor or sensory seizures aware, which means the child does not lose consciousness during the seizures. The other that are a little bit less common, but we can see are the complex partial seizures, where it's again either motor or sensory, but the child is unaware, so there's some kind of change in awareness. And then we can have the secondary generalized tonic-clonic seizures, which might look like grand mal, what we used to call in the past, or just generalized shaking, but this actually starts as focal seizure with then bilateral tonic-clonic activity. This is kind of the new name that is given to this syndrome. What differentiates these seizures from, let's say, a seizure due to some kind of a focal structural abnormality is that this seizure may arise from both hemispheres independently. So sometimes the child may have seizures affecting the right side of the body, or other times the left side of the body. And to understand a little bit about the semiology of the seizure, I would like to talk a little bit about the Rolandic fissure or the Rolandic sulci. So what we see here in the cartoon on the left, we see the Rolandic sulci, which is between the motor strip in red and the sensory strip in blue. And what we see on the right side is the brain homunculus, which maps the different parts of the brain, which part of the body they control. And we see, oh, it's not moving too much, okay, all right. And we see that in the Rolandic area is the area that controls usually the lower lip, the face, and then goes to the arm and to the leg. In Rolandic epilepsy, usually the seizure focus starts in the area of this little arrow, which is the lower lip or lower face, and then goes and spreads into the arm and very rarely into the leg. And that would be how a typical seizure would look like. So the seizure semiology in Rolandic epilepsy ranges from some oropharyngeal symptoms, which can be either sensory or motor, and this is actually the most common seizure type. These are usually focal onset aware, which means the patient is usually aware during that seizure, and that's why they may be a little bit of frightening, because the patient might have symptoms like numbness or tingling or paresthesias or some freezing sensation in the oropharyngeal area, so inside the mouth. It may involve the whole side of the oropharynx, or it might even just be localized to one tooth, so it might be a very localized seizure. The motor seizures would usually manifest themselves as different sounds, like grunting or guttural sounds or gurgling sounds that the patient may have. With many of them, the patient will also have speech arrest. And interestingly, the speech arrest is not due to higher cortical dysfunction. So it's not due to dysfunction of the left hemisphere that is usually our speech area, but rather due to malfunction of the oropharyngeal muscles that are involved in controlling the muscle of speech. So during this time, the patient is actually aware. The patient is aware that he's not able to speak. He might try to communicate with us with different gestures, and that might be also sometimes quite frightening to the patients. The next seizure type that we are going to see are the facial sensory motor seizures, which might involve what we saw actually in the child in the video, where you might have either just motor symptoms like twitching that may start in the lower lip and then spread to the face, and sometimes spread to the arm, which would be hemiclonic of the limb, or sensory seizures where you have just numbness and paresthesia involving your face or your cheek. With most of the seizures that involve the oropharyngeal area, we are going to have hypersalivation due to the inability to swallow and clear our secretion. And more rare or rarer would be seizures that just start with a right arm or left arm clonic shaking. Rarely would it spread to the leg. In about 30 to 50% of the time, and that happened especially at night, the seizure secondary generalized. So when a parent comes into the room, they may just see a generalized tonic-clonic seizure, but at one point, this seizure started focally, usually in the facial area. 75% of the seizure in Rolandic epilepsy are nocturnal, and usually the seizures that are nocturnal are more prolonged. Like I said before, in 60% of the time, the patient is aware during the seizure. They usually do not last more than 1 to 2 minutes. And the diagnosis of Rolandic epilepsy is like any seizure disorder by history. So the history is usually very typical to this seizure type. the typical EEG findings, where we see on this EEG that we have in front of us. So if I want to just remind you, any odd numbers are on the left side of the brain. This even numbers are the right side of the brain. The letters stand for the lobes: frontal lobe, temporal lobe, occipital lobe, and then we see here the central lobe. And what we see here, we see quite frequent spike and wave that are either in the temporal or central region, and they can be either independent only on the left side, or they can be synchronous, like we see here, synchronous both right and left. On the other hand, this one, for instance, is independent only on the left. This one is independent only on the right. This is independent only on the left. And it's very sleep potentiated. So if we have only an awake EEG, the awake EEG may actually be entirely normal, and it's very important to get in these kids a sleep-deprived EEG. These children usually have normal imaging, and if we have the classical story that goes along with Rolandic epilepsy, with this classical EEG, there is actually no need to perform a brain MRI. So what is the treatment? So usually it's mostly reassurance. If the patient has rare seizures, usually we do not need to treat. If the patient has only nocturnal seizures and they're very brief, we do not need to treat. When do we treat? So we treat if there's frequent daytime seizures. And in my experience, it's mostly due to just anxiety that it provokes in the children. It's very unpleasant to have this sensation as if you choke and you cannot control your secretions. If we have frequent generalized tonic-clonic seizures, especially if somebody would have it during the day, which is quite rare, but also if they're quite frequent at night. And the big question is if we have a learning disorder or cognitive problem, and the EEG in these children tends to be very, very active with a lot of epileptiform discharges, especially in sleep. And the question is, do this abnormal electrical activity actually affects our memory formation at night? And we don't have a good answer to that. Sometimes if a kid clearly they do better before the seizure onset and then has some kind of a decline, we might want to try and treat the EEG. However, in Rolandic epilepsy, compared to childhood absence epilepsy, where we are trying actually to clear the EEG, we usually are not able to do it. These children usually will have an abnormal EEG despite the medication treatment. So what would be the preferred medication? So preferably, if the patient has only nocturnal seizures, is to give a medication that we can give once a day at nighttime and not needing to give a morning dose with some of the side effects like lethargy that we might have. Traditionally, trileptal, or now we have actually the long-acting trileptal, would be a medication that would go along well with focal seizures. So trileptal is a medication that is only good for focal seizures. For instance, it would make childhood absence epilepsy worse. Our old friend Tegretol or Carbatrol, we use it nowadays less, but it's still a good option. I think by many neurologists, Keppra or the Keppra XR would be now maybe the preferable choice, because we know that Keppra does not affect learning, cognition, and behavior. And more kind of older medication that we used to use is Neurontin or gabapentin, which we use less. And Zonogram and Wimpad, lacosamide are also possible options. So what is the prognosis? So usually remission by age 15 to 17 years. There was no reported cases of SUDEP, sudden unexplained death in epilepsy, in children with benign Rolandic epilepsy, even the ones who have frequent generalized tonic-clonic seizures at night. In about 1 to 2% will develop what we call atypical Rolandic epilepsy, where they have more severe seizures, different seizure types with atypical absences, myoclonic and tonic seizures, and they sometimes may not outgrow the symptoms. And one of them may develop other severe forms of epilepsy in childhood. For instance, children who start to regress in some of their cognitive or learning abilities. And when we check an EEG, we see that during sleep, the EEG has continuous spike wave activity. It's called ESES. And these children sometimes are treated more aggressively, even sometimes with daily diazepam to try actually and clear the EEG. And that's about it.
I think we're going to switch that
about these two epilepsy syndromes, and we'll continue with
next